Thoracic trauma is one of the most lethal components of polytrauma because injuries to the chest acutely impair three interlocked systems: ventilation, oxygenation, and circulation. Managing these patients successfully requires strict adherence to ATLS principles. You must identify immediately life-threatening conditions clinically during the primary survey before any radiological confirmation. While a specific critical subset of these patients requires urgent surgical decompression, the vast majority can be managed non-operatively with aggressive supportive care and tube thoracostomy. The diagnostic process relies heavily on immediate bedside parameters. You measure respiratory rate, oxygen saturation, heart rate, and blood pressure, while assessing jugular venous pressure, breath sounds, percussion notes, and tracheal deviation. The baseline radiological adjunct is the portable AP chest X-ray, as these patients are typically supine. The most definitive rapid imaging tool is the Extended Focused Assessment with Sonography for Trauma, or EFAST. This maps 6 distinct anatomical windows: the subxiphoid, right upper quadrant, left upper quadrant, suprapubic, right thorax, and left thorax. Mastering these rapid physiological inputs is the only way to accurately separate immediately life-threatening pathologies from potentially life-threatening ones within the rigid ATLS framework. Rib fractures are the most common thoracic injury, but the mechanical behavior of the chest wall varies heavily by age. Pediatric ribs bend, often concealing severe underlying injury. Adult ribs fracture readily. Fracture locations predict internal damage. First rib fractures threaten the lung apex and subclavian vessels. 10th through 12th ribs threaten the spleen and liver. 3rd through 5th indicate CPR. On AP films, anterior ribs appear oblique. Posterior ribs present horizontally. The primary management directive for simple rib fractures is adequate analgesia. The obsolete practice of tight chest strapping is strictly condemned because it restricts ventilation and promotes pneumonia. A more severe mechanical failure is flail chest. The strict criteria require 2 or more consecutive ribs fractured in 2 or more places. This creates a free-floating segment of the chest wall that moves paradoxically, inward on inspiration, outward on expiration. The primary driver of mortality in a flail chest is not the mechanical bone fracture itself, but the underlying pulmonary contusion. Management follows a stepwise pathway. Administer oxygen, establish deep analgesia, often via a thoracic epidural, and if respiratory compromise persists, initiate intermittent positive pressure ventilation. The explicit clinical triggers for intubation and IPPV are a respiratory rate greater than 20 breaths per minute or a PO2 of less than 60 millimeters of mercury. In these severe cases, IPPV functions as an internal pneumatic splint. Severe structural failures of the chest wall are ultimately stabilized by internal pressure management. Moving past the bones, a simple pneumothorax involves pleural air without hemodynamic compromise. An open pneumothorax requires immediate closure with a 3-sided occlusive dressing. The most lethal pleural complication is a tension pneumothorax. A one-way valve traps incoming air. The progressive pressure rise collapses the lung, forces a mediastinal shaft, and mechanically compresses the vena cava. Tension pneumothorax is a clinical diagnosis. The classic tetrad is hyperresonance, absent breath sounds, raised JVP, and hypotension. If an EFAST is performed, the ultrasound shows the normal seashore sign degrading into the barcode pattern. The absolute mandate is immediate needle decompression. For adults, insert at the 5th intercostal space, mid-axillary line. For children, the landmark is the 2nd intercostal space at the mid-clavicular line. Contrast this pressure failure with a volume failure, hemothorax. This drives hypovolemic shock, characterized by dullness to percussion and X-ray signs like a complete whiteout of the hemothorax. The rapid bedside distinction between hyperresonance and dullness instantly reveals whether cardiopulmonary collapse is being driven by trapped air pressure or catastrophic blood volume loss. Tube thoracostomy is inserted within the triangle of safety, bound by the axilla apex, anterior and mid-axillary lines, and 5th intercostal space. The tube penetrates the chest wall over the upper border of the lower rib, safely bypassing the intercostal neurovascular bundle. The drain connects to an underwater seal system, allowing fluid and air to exit without being sucked back in during inspiration. A swinging water column confirms correct intrathoracic placement. The tube remains until the lung fully expands and drainage drops below 100 milliliters in 24 hours. Removal is executed while the patient holds their breath at peak inspiration. Emergency thoracotomy is indicated if there is greater than 1.5 liters of immediate blood drainage upon insertion, or an ongoing loss of greater than 200 milliliters per hour for 3 consecutive hours. Beyond treating the mechanical failure, tube thoracostomy provides the volume data that dictates the threshold for emergency open surgery. Cardiac tamponade presents as profound obstructive shock, triggered by the rapid accumulation of as little as 60 milliliters of blood in the rigid pericardial sac. The clinical presentation is Beck's triad: hypotension, raised jugular venous pressure, and muffled heart sounds. The definitive diagnostic view is the subxiphoid cardiac window on the FAST exam. Because trauma blood often clots, clinical guidelines have moved away from needle pericardiocentesis. The current mandate is an emergency left anterolateral thoracotomy or a sternotomy. Another lethal central failure is traumatic aortic injury. Driven by massive deceleration forces, structural failure typically occurs at a specific focal point of shear stress, just distal to the ligamentum arteriosum. Clinical signs include a widened mediastinum. For stable patients, CT angiography is mandatory. Unstable patients require transesophageal echocardiography. Interim pharmacological management relies on short-acting beta blockers, like esmolol, to keep the heart rate below 80 and maintain permissive hypotension. High-energy impact to this region often results in sternal fractures. The structural failure demands strict surveillance for myocardial contusion, using serial ECGs and cardiac enzymes. Mediastinal injuries represent the apex of trauma lethality. Even minimal fluid shifts or isolated shear stress guarantees cardiopulmonary collapse without aggressive surgical control. At the lower margin, we assess diaphragmatic ruptures. These predominantly occur on the left side, as the mass of the liver provides a protective buffer for the right hemidiaphragm. The key clinical indicator is hearing bowel sounds within the thoracic cavity. If a rupture is suspected, there is a critical safety warning: never insert a chest tube blindly. Definitive treatment requires a laparotomy to reduce the herniated abdominal contents, repair of the diaphragm using heavy suture like Prolene, and placing a chest tube strictly under direct vision. Transitioning superiorly, cervical trauma is mapped by rigid anatomical zones. Zone 1 runs from the thoracic inlet to the cricoid cartilage. Zone 2 spans to the angle of the mandible. Zone 3 extends to the base of the skull. Zone 2 is the most exposed, the most commonly injured, and the most surgically accessible. Zone 1 carries the highest mortality rate due to the dense concentration of vital vascular and airway structures. Intervention is driven by the presence of hard signs, indicating significant injury: subcutaneous emphysema, air bubbling from the wound, an expanding hematoma, and hoarseness of voice. Zone 2 injuries with hard signs demand immediate surgical exploration. Because surgical access is constrained in Zones 1 and 3, those injuries typically rely on angiography and embolization. In these transitional anatomical zones, the geometry of surgical accessibility strictly dictates whether a patient receives an open operation or an endovascular intervention. When confronted with a hypotensive, tachycardic trauma patient, practitioners face a rigid diagnostic test. You must instantly categorize the systemic failure as obstructive or hypovolemic, relying entirely on your hands and a stethoscope. Obstructive shock with absent breath sounds, hyperresonance, and raised JVP diagnoses tension pneumothorax. Hypovolemic shock with absent breath sounds, dullness, and low JVP means hemothorax. Obstructive shock, raised JVP, normal breath sounds, and muffled heart sounds indicates cardiac tamponade. Beyond hemodynamics, isolated mechanical red flags demand immediate recognition. Paradoxical chest movement signifies a flail chest. Bowel sounds in the thorax indicate a diaphragmatic rupture. Anatomical hard signs in the neck mandate urgent vascular or airway control. Life-threatening thoracic conditions are diagnosed clinically at the bedside. In the acute trauma setting, radiological imaging is strictly an adjunct to, and never a substitute for, decisive immediate physiological intervention.